I'll let you know today we're going to talk about the hormonal therapy that's involved in pediatric and adolescent gender medicine. And are we good, Summer? Okay. So hopefully today, after you listen to this session, you'll become more familiar with the hormone options that are available. You'll also understand the process that is used in pediatric and adolescent gender clinics for hormonal therapy. And then to be really aware of how you can partner with your mental health providers to help the process and initiate hormonal therapy for this population. So, as an introduction, pubertal development just happens between 8.5 to about 14 years of age to those who are designated female at birth. And then for those who are designated male at birth, their puberty tends to happen a little bit later at about 10 and a half and starting to 16 years in age. And puberty, people always think about the physical development, but we also have to remember that it actually involves three separate parts. Most of the physical development is what people see. So say people will say, oh, puberty is starting, and often that development happens at an earlier time. But the other part when I talk about brain development is really thinking about the kind of neurons that start to be formed and executive function and the frontal lobe and the connections. So really going from concrete thinking to more what ifs and those decision making skills, right? What if this happens? What if this happens and then the branching logic and this doesn't happen? And so planning for that future is something that starts during puberty. It's also a time for psychosocial development. So not only in terms of, okay, I want to play on the playground with so and so, I know so and I have similar interests, but where the crushes start, maybe romantic attractions can start. And for some, it might actually also result in sexual behavior as well. So all three are happening at the same time, but the amount of development may be one might be a little bit forward, one might be a little bit back. And that becomes an important issue when we have guidelines. So, again, remembering that our transgender youth may identify at any age and come and seek hormonal care for us. But that doesn't mean we treat anyone who comes at any age on hormone therapy. So, hormonal intervention doesn't really start until puberty actually starts. And I want to emphasize this because a lot of the anti trans movement and on the media, people would say, you know, you may have a 3 or 4 year old who comes to our clinic, and what we're doing is giving a lot of psychosocial support, wanting a child to understand gender roles, to be able to explore kind of their identity, their expression, and feeling safe to do that are the things that we advocate for and work with schools. But the headline news will say 4 year old comes to gender clinic and doctor offers hormones and surgery, right? So I want to make it clear that is not what we're doing at all. So there are three typical presentations at which we'll get patients that come to our clinic. Either they're presenting before puberty or at an early stage, they're right in the early to middle stages of puberty, or they come after puberty. And each one of those will go through a scenario of what happens. So if someone comes before or at an early stage of puberty, we're going to wait until puberty starts if they're young and there's been no signs of puberty. So if you're programmed to have puberty with estrogen, it's breast budding is what we look for. And if you're programmed to have puberty with testosterone, then it's testicular enlargement. Now, the breast budding, most parents don't miss. And I think other adults, just because of the way clothing is worn and it might be noted. But the testicular enlargement often gets missed because, you know, the slight changes that are starting, you might not notice at all if the children are themselves bathing themselves and going to the bathroom themselves. You know, it's really hard to tell. The following are actually not signs of true puberty, but more of what we call adrenarche. Because everybody, and I have to tell our patients, everybody gets hair under their armpit. Everybody gets hair down below, right? So axillary and pubic hair. You're going to get pimples, oily hair, oily skin, where you actually have to use shampoo and soap and, wash your face with cleansers. Everyone gets body odor, needing to wear deodorant. And this does not come from the ovaries or the testes. Actually, where it's coming from are the adrenal glands, which sit right on top of your kidneys. And these are the signs of adrenarche, or when the adrenal glands start making androgen like hormones. And so everybody makes it, and everyone is a balance of estrogen and testosterone or testosterone like hormones. So, because of that, these signs will come up. These alone are not meant to say that puberty has started. So, we will not intervene when we notice these changes are there without breast buds or without testicular enlargement. So, when we're talking about the elephant in the room here, which are pubertal blockers, I actually like to think about it as pubertal pausers because what we're doing is putting puberty on hold for a little bit. And what it is that it's a synthetic form of the message from the brain to the ovaries or the testes. So the message from the brain to the ovaries or the testes is going to be sent by, you have your brain to the pituitary, and it sends a message called GnRH, or gonadotropin releasing hormone. And then your pituitary gland makes luteinizing hormone or follicular stimulating hormone, and that gets the ovaries to make estrogen and the testes to make testosterone. And the way it's made is really important. It needs to be in a pulsatile fashion, meaning going up and down, up and down. And if it's not pulsatile, we've learned over time that things get turned off. So what we do when we're using a GnRH agonist or the pubertal pausers or blocker is that by giving this medication as a form that's going to stay in the body for a really long time, the pulsation that you're making in your body is gone, and you just have one maintained level. Because there's a maintained level, what happens is the brain, particularly the hypothalamus, doesn't tell the pituitary to continue to make the signals LH and FSH to the ovaries or the testes. And because that signal is there, your own gonads stop making the estrogen and the testosterone. So it's a very unique system. And what we're doing is taking advantage of the physiology. So in order to have our pubertal blockers work, we need to have them come into the body and stay in a really long time. And that's why they're offered as a depot or a long kind of in the body system. You have either injection form or an implant form. In the injection form, they come in multiple formulations every month, every 3 months, every 4 months, or even every 6 months. And then in the implant form, it comes as every 12 months. However, we are able to kind of manipulate the system a little bit. So we know, and what I'm talking about is from an insurance standpoint. So if I have someone who's younger coming in and I know they have to come all the time for injections, part of something that I'll screen for is, how disruptive is it for the family to be able to come? And are we going to be missing school? What's going to be happening? The manufacturers actually have kind of set the price the same. So that 1 year of treatment is about $25,000 for us. So if you have a 6-month formulation and you're going to get it as an injection, they charge for that one injection probably about 10 to 12 grand for the injection so that they still get the 25 grand. And then you can imagine, right, if it's going to be a 4-month formulation, a 3-month formulation, how it's done. So it's not a cheap medication. And it's particularly not cheap. When I showed you on the injection, there is a picture of a child on it. That is the pediatric version. Now, you can get the adult version of the same medication biochemically, but the picture of the child is gone. And just by doing that, the price has decreased by about a third. I don't know if we have anyone from pharmaceutical, big pharma, but one way that we may sometimes try to get with lower pricing is instead of prescribing the more expensive pediatric version, if families aren't going to be able to pay, is I'll go and prescribe the adult version. Anything I do is off-label anyway, because the FDA had never said this was for pausing puberty in gender dysphoria or transgender. These medications were made for precocious puberty or puberty happening too early. So this experience with early puberty and precocious puberty is what allows pediatric endocrinologists to use these medications very comfortably. The other side, which is the histrulin implant, it's placed under the arm. It takes just probably 10 seconds. It's kind of like a Depo-Provera, not Depo-Provera, what do you call it? The implants, that goes in, and there's 5 of them, and it goes right on under Nexplanon is the word I'm looking for. The only difference is this is a lot more softer, and it is clear. If I were designing the medication, I would have made it like bright green so that once it's in the arms and you had to remove it later, you could find it. But the fact that it's kind of clear to almost like a pinkish tone, like skin tone, it makes it really hard to find later. It takes maybe 1 stitch once it's placed, and it's pretty quick to do. Our site, Stanford, was one of the original sites when the histrulin implant was made. And so we looked at it to see how it competed to the injection and how long it would last. And we knew, even though the FDA approval is for 12 months, we knew that it continued to keep working. So with that, we just followed the patients afterwards to see, when does it finally not work anymore? And it ranges from like 22 to 27 months. So we take that as an average about 2 years. And I say you already get it half price because you could have it be placed. And then instead of taking out at the end of the 12 months, I'll use it until there's no function. So I will leave it in for about 2 years worth. So instead of 25 grand per year, now we get 25 grand for 2 years. These medications, the youngest I've used it in, believe it or not, is a 2.5-year-old. They came in for, Anna. So I had a referral for abnormal thyroid testing. And I looked at the patient and I did the exam, and I was like, okay, I understand you're here for the thyroid, but what I'm really worried about are the breast buds. And so the child ended up having precocious puberty. We worked up to kind of see it was idiopathic. We worry about brain tumors, things like that. And we kept the little girl on a blocker until they were about 10 years of age, and then let puberty proceed then on. So I think using it in a young age is not something that we are uncommon with. In the adult world, it's used for breast and prostate cancer. So after having been diagnosed either with breast or prostate cancers and they're sensitive to hormones, sometimes they're blocked by using GnRH agonists so that the cancer does not come back. The considerations that we use in timing of the blockers, the biggest thing is the bone health. And what you have to remember is, people are really worried about it because there's all these things out there that says, oh, if you're on a blocker, you might break your bones. The blockers do this, the blockers do that. But kind of thinking about it, and this is my area of research, is that sex hormones are needed for bone development. So everybody kind of starts out as the same as a younger youth, if you're designated male or designated female. And depending on when you get exposed to sex hormones, your bones are going to become stronger. And that's when things start to diverge. So that estrogen bones are shaped a certain way and may have a certain strength. And then later on in life, be at risk for fractures at a different rate than if you were exposed to testosterone. So all bones kind of, start together, and depending on how you're exposed, it's going to really make that difference. Now, when you are paused from making any type of sex hormones, what happens is the bone density is going to decrease while on therapy relative to the peers that you're comparing to who are going through puberty. So if you have two 12-year-olds, but one is blocked and one is not blocked, meaning one is seeing sex hormones and one is not seeing sex hormones, the one who's continuing to be exposed to sex hormones is going to have stronger bones because the bones need the sex hormones to become stronger. And the one with the pubertal blocker who is not seeing any sex hormones is going to have a density that's lower because they're not being exposed to any of the sex hormones. So when you do that comparison, we always see and aren't surprised that their bone density is going to be lower. So we assume everyone's going to be lower. So what we do is we maximize that bone strength. You have to have maximum amount of calcium. So that's about 1,200 milligrams is what I would recommend of elemental calcium. You need to have vitamin D, so definitely pushing for a level above 30 as a minimum, and then to do weight-bearing exercises. At minimum, I would love to have 30 minutes 5 days a week. I recommend at least 50 minutes 5 days a week. And it is weight-bearing exercises, so it is anything except swimming, because obviously in swimming you're floating, so it's not weight-bearing. And everyone has to agree to do this while they're on blockers. I don't necessarily get a DEXA scan every single year. And the reason is that if you get one DEXA scan to have good data, you have to have the same machine, check it out every single year. And it's just an exposure to the radiation. And I feel like it doesn't actually add anything clinically because you already know the bone density will go down a little bit. And if you ask the families, okay, I'm noticing your bone density is going down. We want you to do all this for treatment to maximize it. Or do you want to come off the blocker and continue with pubertal development? When we offer that, we've never had a family really want to come off of the blocker just so that their bones can be maximized. The advantage, of course, of why we use a blocker is by pausing the physical development of puberty, it gives the patient more time to explore the gender identity and as well as exploration of who they are themselves and what they want to do in terms of options. And that's why we use blockers. So after they're on blockers, and their gender identity and exploration is complete, with a mental health provider who's trained and kind of has coached, around 14 years of age, that's when we may decide to start with gender affirming hormones, either of estrogen or testosterone. And what we typically do is we're going to titrate it to induce puberty over about 2 years of age. Again, as a pediatric endocrinologist, I've induced puberty in our kids who don't go into puberty. So some of our hypogonadal, hypogonadotropic kids, meaning that there's something wrong in their brain with their pituitary gland and there's no messages that get sent, or their ovaries and their testes, something has happened to them. And so there's no way they're going to make those hormones. So we're used to being able to make puberty occur for them. So we induce them typically over 2 years because for normal puberty, you develop over 2 years. And if you do it too quickly, you don't want someone to grow so quickly and still reach that same potential height. So if you say, if I can make someone grow really fast and I do it for 2 years, they're going to maintain that rate. So they're going to end up taller. Unfortunately, that's not kind of how the line works as linear. It starts to plateau. And the reason for it is because you have a program adult height, and you might reach it there a little bit sooner. So we'll come back of how we kind of give the estrogen and testosterone later. But let's talk about scenario 2, when someone presents at middle of puberty. So up to the middle of puberty, which is about Tanner 3, possibly Tanner 4. So Tanner 1, if you remember, is no signs of puberty. You're born at Tanner 1. Tanner 2 is early puberty, when puberty starts. Tanner 3 is right in the middle of puberty, which is what we're going to talk about right now. So up to that, we offer the pubertal blockers. And the reason why we offer pubertal blockers up to middle of puberty is that the body hasn't had a ton of exposure to the sex hormones, whether estrogen or testosterone, so that if we were to take it away with the administration of a pubertal blocker, in 4 to 6 weeks, that level of sex hormones going down isn't going to be as missed as if you were later in life. So if you were already past all your pubertal development, and then I took away your estrogen or took away your testosterone, you would feel a decrease in your energy level pretty quickly because your sex hormones were gone. You could have a change in your mood pretty quickly from having the loss of the sex hormones. And for those who are exposed to estrogen, the number one complaint we get in just 4 to 6 weeks are hot flashes, because I have essentially given somebody menopause in 4 to 6 weeks. And menopause, again, happens slowly over years. But just to imagine to go through all those symptoms in 4 to 6 weeks, it's pretty miserable. And so that the side effects may be greater than the benefits. And that's why we only offer pubertal blockers up to about the middle of puberty. So if you come after full puberty, Tanner 5, we won't offer a pubertal blocker, and instead we might have to just go straight to estrogen and testosterone. And we'll talk about supportive care. So I talked about Tanner 1, where there's no puberty, and in that you get no hormonal treatment yet. Tanner 2, you can have a blocker. Tanner 3, you can have a blocker. Tanner 5 is no blocker. So what happens to Tanner 4? So Tanner 4 is hard to tell. It's a smaller window. It's usually someone who has not started their periods, but you examine them and you know they're within just right there to be able to start. And for those with testosterone production, it's that growth spurt is just starting. You're noticing a lot more acne, and the changes are really coming on of deepening voice and kind of the facial changes. What happens with Tanner 4 is, depending on their level of hormones, I need to make a decision to say, if I take away the sex hormones, will they be experiencing those withdrawal symptoms? The other thing to talk about too is, especially if we take away those symptoms, what is going to be the benefit? Because sometimes we have, particularly in those designated female at birth, they might be at Tanner 4 and they're only 10 years old and they're about to start their period soon. It's going to be almost 4 years before they're going to be eligible to do any gender affirming hormone treatment, maybe 3.5 years. So what do we do in the meantime? If they've only had one period maybe, or not had one yet, I might say, let's do a trial of a pubertal blocker, but not to put in an implant that's going to be there for 2 years, but maybe like a month trial, 1 or 2 month monthly injections. See, how do you feel from having some of the decrease of your estrogen production? Are you having the energy changes? Are you having the hot flashes? Are you having the mood swings? Can you tolerate that? Can you work with your mental health provider and other meditation, other ways to kind of, deal and have a toolkit to be able to feel the symptoms? And if you can, then we'll continue for longer term and switch over to longer durations of a blocker. And if you can't deal with it, it's okay, because it was only for a month. And then we're going to have to do supportive care. So what are the other hormones we provide for supportive care? Spironolactone, or on the streets it's known as Spiro, is something that we offer. It's a medication that is often used by our dermatologists because it's something that blocks the adrenal gland. So we talked about adrenarche, and I call all the problems for teens, right? Because it's going to help with the acne, the body odor, the body hair. So it affects all the body hair except your axillary hair and your pubic hair. So what is known as vellus hair, so hair on the arms, maybe facial hair, pimples. What it does with the hair is that it allows the hair to grow back at a slower rate, or it's going to still grow back, but it'll be more fine, or you get both. So it's really helpful for those who are programmed to have testosterone. They might want some spironolactone so that it decreases their androgen, and maybe the hair removal that they're doing, especially of their face or their chin, doesn't have to be as often, or it's easier so that they look much more clean face and can pass better. Spironolactone, as you know, is a diuretic. And because it's a diuretic, it's going to be a medication that can cause people to pee, can have lower blood pressure. That's what the original use was for. And it's done by potassium sparing. So you have to make sure that the potassium level is checked before and then after. And if we notice a slight increase in the potassium, here in the mainland, it's not a problem because I say just eat less banana, oranges, and pineapple. But where you are, for Hawaii, it might be harder having to avoid the pineapple because it's so delicious there and people might eat it more often. But that does have higher levels of potassium. We rarely see it. Maybe in 1% or less of our patients actually have an impact on their potassium where we need to intervene. The other hormones that also provide supportive therapy is menstrual regulation or menstrual suppression. We like to regulate so that you eventually get to suppression or no more periods. There's the combination pill, which is the pill. A lot of our patients don't want the pill because they say there's some estrogen that's involved, right? It's estrogen along with progesterone. What we typically do is have everyone continue to take the estrogen pills, but not take the sugar pills or the placebo pack, and instead go straight to the next pack. And so basically by continuing and not ever taking the withdrawal bleed with the sugar pills, you've kind of suppressed their periods. It works a lot better than I think if you just do without the estrogen. But again, just the mentality of, I don't identify as a female. I identify maybe non-binary or more masculine. And here you are making me take estrogen, just kind of doesn't make sense for me. So I don't want that. That's the number one complaint. Many combinations of the combination pills. Then there's also the mini pill, and it's called a mini pill because that's a progesterone only pill. The way that works is that it mimics the body in thinking that you're pregnant and the progesterone levels remain high. And by having constant high levels of progesterone, you wouldn't ovulate. And that's how this medication got started. The thing that's really important about the mini pill is that it needs to be taken within an hour every single day at the same time. And if you don't do it, it's pretty easy because the patients will have spotting and they're not being as adherent to the schedule as it should be. So that's usually our most popular one. And then the next one, of course, is an IUD. Some people like it because they don't want to have to take a pill and they feel like having an IUD makes it a lot easier for them. It's in, and once it's in, I don't have to think about it. Depo-Provera injections are also another option that some people would want. And I think when we're thinking about what is the best method is also having a conversation, not about menstrual regulation, but if there is any sexual activity, what type, and thinking of what partners to see if contraception itself is also needed, not just for menstrual regulation, but contraception, and then finding the best regimen. If someone goes on to testosterone, We like to start with injections. And when we're doing injections, I like it because I can titrate from the smallest amount to the appropriate amount adult doses. There's a weekly way that you can do it. There's every other week is what we typically do. Some people come in for a monthly injection. Later, when you're on adult doses, there's even a pen device that allows you to kind of hide it. It kind of looks like an insulin pen, and to be able to give it so you don't have to see the bigger needle. There's also patch, gel, foam. The patch, gel, and foam are daily. And so because it's kind of viscous and an oil, you really have to we have a whole process of how you administer it, how you put the gel on. It takes time for it to dry. You want to wash your laundry separately so that it's not kind of being passed to other people. And because it takes longer, some of our patients, and having to do it every single day, they do not prefer this. Some people also get rashes. In order to do the testosterone injection, there is one allergy to be careful of, and that is to sesame, because the oil in which the testosterone is suspended in is in sesame. So if you have a sesame allergy, you will have a reaction to the testosterone, and you may need to have it be formulated at a compounding pharmacy in a different type of oil. In older adult doses, you can get an implant done. I think I've sent one patient. The reason is the implant usually is placed by urology. You could have an adult who's trained to be able to place it. It's easy by all means, but you have to replace it every 3 months. So a lot of our patients don't want to come in to go through a little procedure and have a new one be placed and taken out every 3 months. The effects of testosterone can be seen sooner, so the masculization comes a lot sooner than estrogen. And so people are much happier about it because they notice changes. And one of the first changes may be like their voice that's happening. So people are like, wow, it really helps to affirm me sooner. Things I monitor for are the hematocrit, lipid panel, liver enzymes, and of course the hormone levels to be adjusting. And it's the hematocrit getting too high because testosterone increases erythropoietin production, which can increase the hematocrit. For estrogen, the number one way we prescribe it is by the pill, usually taken sublingually to kind of bypass the effects of the liver. Patches are also available. Sometimes they're more expensive, so we have to try to get it covered by the insurance. And if you haven't tried the pill, some people don't like it. Injection, I don't use as often. Be careful, there's 2 types of estrogen oils. Same thing for testosterone, but one of them's really no longer made. So you want to make sure, because one is doubly potent as the other. So you want to make sure you can't say, oh, I have this one estrogen and I've got the other and I can go back and forth with it. Again, because estrogen works a lot slower, you want to be careful in using it, because not careful in using it, but careful in telling the patients as they're using it that you have to be patient and not to over give it to themselves, because they're trying to see the effects much sooner. We're going to monitor the hematocrit still. I rarely see it go the other way, in which someone becomes anemic because their erythropoietin goes down with the lack of testosterone and estrogen is going up. The liver can have its effect, just kind of how maybe lipid panel may be impacted, and of course the levels to help you titrate. Progesterone is another medication that has had some popularity, particularly in our trans feminine patients, because not everyone uses it. I'm saying that there's variation in practice. Those who've had a combination say that's what you absolutely need for best chest development. But a lot of people have undergone the development without progesterone. And one of the things I'll usually try to do is maximize the estrogen and then add in progesterone. And part of it is because it does increase the coagulopathies and the risk for it. So I want to try to make it as risk-free as possible. Glutamide is another medication and this is an androgen receptor antagonist. We in our clinic have only used it a few times for somebody. The things that I worry about really are the reasons in that the side effects can cause hematuria, swelling, bloating. The shortness of breath is pretty notable, myalgias and congestion, so kind of really aging them. And a lot of our patients don't want those risks. So what I might, rather than just doing an androgen receptor antagonist, when they're on estrogen and you're not getting a great effect, they're already on progesterone and they really want something else to see the impact be better, and they're adherent to treatment, is to actually later on add in a pubertal blocker so that you have enough of your estrogen in your body and then having the pubertal blocker to decrease the testosterone to give you the changes that you need. We talked about GnRH agonists earlier, but there are GnRH antagonists as well, and they're really used more in the adults rather than the kids, and it's just because there's a bigger impact on bones with the faster action. So the impact that you're going to see on your bones, you'll see within the first month of that bone density really decreasing. It's really used for like endometriosis, for like quick relief of symptoms and whatnot. So in the pediatric world, we almost always only use the GnRH agonist and not the GnRH antagonist. By the way, all of this you'll get as PDF on your slides because I know it's a lot of details of these medications to kind of help you. And then when do we require letters? Letters are something that we work with our mental health providers, and with the SOC 8 from WPATH, they're no longer letters, but kind of like the clinical summary, but essentially it's a letter. In anyone that's under 18 years of age. And the reason why I'm asking for it is because I want to make sure that the family and the patient have kind of really thought about why they want hormone therapy. They understand the implications. What are the goals they want to reach? Because sometimes one of their goals may not be able to be reached by hormones, and it's just surgery they need, and they may never need hormones. And then they also need to be evaluated to be ready for the therapy. And we really break it down in steps at our clinic, in that you do one evaluation for blockers because you might be younger. And then when it's time to be starting estrogen or testosterone, you do a separate evaluation. So that, is it time to add in testosterone or is it time to add in estrogen because you've decided whatever you're programmed to have for puberty doesn't align with who you are. The benefits of the letter is that it's really the true informed model, right? In the sense that the family has worked together with the mental health provider and the medical providers. And it's a way for the youth and parents to think about the hormones together. It's almost one of the only reasons sometimes being forced to go to a mental health provider for the first time. And I like to actually think of them as coaches. And I tell them it's like a coach. They're going to help you think about these things and the what ifs and make a plan and go through different scenarios that you're going to play out to help you kind of develop your identity and make sure. And because you have this coach or mental health provider, behavioral health, they're kind of a mediator. And it's an opportunity for parents to express their worries and the youth to really explore and have a comment back and have a discussion. And I think if it's mediated, it's always much better than at home when they're kind of arguing or not even talking to each other and communicating. So when we get these letters, what we often do is our whole team reviews it, the medical and the mental health, to make sure the components are there appropriately. And if the hormone therapy has been agreed upon as the next steps, then the medical consent is reviewed, and we review it with the family and the patient. We don't ask them to give it back to us immediately. We actually ask them to go back and ponder everything that's written so that they have some time to think about it. We talk about what are side effects that we went on to talk about, long-term effects, permanent effects, etc. And then after the time for contemplating about the consent, they'll sign it and we get baseline labs and we're ready to go. So really getting a letter, a consent, and labs are the 3 steps that we often ask for. And by doing that, it really, I think, gives an informed model of the families working together to really understand what the transition is and to see if they're ready for that specific treatment at that time. Other roles that we continue to work with the mental health provider for is each time I'm going to make a dose adjustment, I ask not only the patient, how's it going? Because most of my teams say, oh, it's great. I just need more. Absolutely. So I want to make sure what is the parent thing? How's it going in school? What is their mental health provider who's continuing to think to see how, is the mood stable? Are there other risks that are going on that we need to not increase? For instance, if there's a lot of aggression and anger, things that are being worked out, maybe I shouldn't just, increase the testosterone by whatever the amount. I should go a little bit slower so that there's not more aggravation. And just kind of with therapy, continuing to talk about what's their exploration and goals, understanding there's going to be ups and downs, especially with estrogen. It's like, yay, I started gender affirming hormones, but it's taken so long for me to transition that I'm now frustrated. And also, treating with hormones isn't going to make everything go away. The anxiety, the depression, if there's disordered eating, that may still continue because gender is not always just the only situation that's occurring. And the main thing I would like to stress is in anybody who has a mental health provider and they're working with us in our clinic is having that two-way release of information that we ask everybody to sign so that I can communicate my concerns to the mental health provider and the mental health provider can be telling me what's going on so that we can make our regimens be appropriate. So with that, I wanted to end a little bit earlier to give more time for questions because I know there was a lot more information this time than last time. So I'd like to be able to answer questions. Or if you have cases as well, I'm happy to take them. One thing I'll throw out there, sometimes people ask about fertility. And that was one thing I didn't put in my slides, but if fertility is something that comes up, just to let people understand that while you're on a pubertal blocker, it is true, your fertility is turned off because you're not making any or maturing any ovaries and you're not maturing any sperm. If someone just is on a blocker and you just remove the blocker, then everything goes back to how things were in like 3 to 6 months time. And there's no long-term impact on fertility. If you're on a blocker and then you decide that you don't want the puberty that you're programmed to have, but you actually want the puberty that you are going to be that's going to be aligning with your gender identity. So it's going to be exogenous puberty or puberty that a doctor does with pills, then or injections with testosterone, then of course your fertility is going to be impacted. If you were never on a blocker and you just start, we know that the longer you're on estrogen or testosterone and the higher the doses, the longer it takes for you to have to stop that treatment and for everything to kind of reverse to see if the fertility can come back. So that's just one thing to remember. So
I don't see any questions in the chat just yet, although I do feel like they tend to come more easily the closer we get to the end time. So maybe why don't we go over the post survey questions and then the post questions, and then I will pass along other written questions in the chat as they come along. And yes, one came up.
Have you had children who have had parents who selected the child's gender who then the child wants to reverse? So If you're talking about a young child, you mean designated at birth, and then the child says, I don't like that designation, and then I want to change, that is, yes. So if, like, let's say in cases like disorders of sexual differentiation, DSD, the babies who are born and the children who have been designated one way, and then those patients say, that's not my designation that I want to reverse. And depending on what that disorder is, we will go ahead and make the gender, I mean, it would just be like coming to gender clinic and us helping them to transition. And implanted fetuses for gender selection. So, at least where we're serving, we have a lot of IVF babies. And so the parents may have chosen an IVF baby based on sex, but when the baby is born, their gender identity is coming in, and it becomes of a different one. We do need to go through the same process and do the evaluation. And I can say, I don't know what percent, but I would say at least 5% of our patients are probably from IVF. And parents have put in a lot of, when which egg or which sperm, and how they chose of which embryo got implanted. And sometimes it is hard. And we talk about the parents kind of going through a mourning because they feel like they're mourning the loss of a daughter and always thinking about gaining a son, or vice versa. So that does happen. Can you discuss any long-term? Yes, I did talk about the negatives to hormone therapy, depending on which hormone and why. So I think in the notes it would be easier because I'm not sure which one, but each one of the hormones has risks. So biclutamide, for instance, is the one that's known to have some risk with hematuria. We don't use it too often. Liver, you can also see for testosterone or estrogen. But I will tell you, all these risks that we talk about, at least in the pediatric literature, and when we've been to conferences and looking at it, it occurs in like less than 2% of the patients. And I think it's just because our kids are at a younger age, the livers are healthier, or, kids are more resilient. And so right at the time when we're monitoring these labs, and we monitor them annually, after the first initial, there's a baseline of 3 months and then 6 months, and annually, we don't see big changes at all. I just don't know what the future will hold when they're middle age or older. And I think as we're having databases of data being collected for hormones in these kids on treatment, we'll have a better understanding. So even though we continue to look and monitor, it's very, very rare that we see something. If we see anything with the liver, they already had started with some fatty liver due to like their BMI and lifestyle before, and then we'll really work with them with our registered dietitian. You're very welcome. I'm just looking here to see. So are people done? Oh, it's only 8 of 20 have participated, so I don't want to give away answers. Yeah, so long-term kind of to help monitor and manage, I think resources and recommendations is to use WPATH guidelines. The Endocrine Society has their guidelines as well. And then for peds, there is a specific written, and it's in the current opinions of, I think, Pediatrics and Adolescent. And Jimena Lopez is the first author. But if you use the endocrine guidelines or the WPATH guidelines, they all say the same of how to monitor, but most of it is annually. And so the labs that I've included under each slide and what we're monitoring are things that we look at once a year. Especially for our older adults, I think it's just, doing the regular screening with the lipids, the hemoglobin A1C, CBC, basic metabolic panel. So nothing to, and then of course your hormone levels. Where I see sometimes in our adolescent young trans males is they want that transition and they want to be super masculine. So do be careful of levels that are really high on that testosterone, because they don't want just normal designated male ranges, but they're trying to be like, I want 1,000, I want 1,500. And those actually then have scary implications of more of the side effects and whatnot. In the state of California, when we're prescribing testosterone, it's actually the same level as an opioid, in that it is scheduled you need to write for it, you need to have it be checked. And once you write for it, you can't rewrite for that same person for more than every 28 days. And the prescription goes kind of in a state database, so that the abuse of it or the increased use isn't there, and mainly for sports performance as well. Other questions?
Those are the ones I see so far. How are we doing with our post-test questions? Maybe we could go over those quickly.
How about 72%? So
okay, everybody.
maybe I'll end it there.
And then do I give the answers, or?
Yep,
Yes,
you can go over
please.
that.
Okay. So the answer was Tanner 2 and 3. And this is tricky because for Tanner 1, there's no puberty yet. So that's why we would not choose A, because it was 1 and 2. So only 2 would be eligible. And then nobody picked the other one. So that was just the trick in that. If there's no pubertal development yet, and everyone starts with the Tanner 1, so you can't give a pubertal blocker till there's pubertal development. And that's important, particularly for some of our primary care providers and families who are coming in. All the forms of testosterone option, and I think we were going to go from single choice to multiple choice. So yes, foam is a choice, gel is a choice. In fact, the foam comes in a deodorant form, meaning underarm form. And I always tell my patients that yes, you could do it under the arm, but do it the opposite of the deodorant, because they didn't make it as to work like a deodorant. Gel works, patch work, injection works, and pellet works. And nobody chose sublingual. So in a way, everybody got that right. And then spironolactone can help with everything. Yes, it will help with acne. It will help with facial hair and leg hair, but it does not actually help with voice, because voice has to change with thickening of the vocal cord. And that only happens with testosterone. And that's why if you already have a lowered voice in our trans feminine patients and they want to change to a higher pitch, oftentimes you need surgery, because it is the vocal cords that has changed. So I know this time the topic was a little bit more dense in treating. And I think that's why oftentimes some of our primary care providers want to partner up with those who give the hormones more often, just for all the nuances. But hopefully you found this to be helpful, or at least you know what the treatment your patients will be on, and to continue the management. So thank you.
Thank you. Thank you so much. I have to admit, as much as I always felt it was a bit of an intimidating topic, thinking about the various hormone replacements, especially, it's honestly even so much more complex than I think I would have initially thought. And really having that overview has been so helpful and makes it seem so much more manageable on an outpatient setting as well.
Yeah, there's no special license needed in California to prescribe hormones. My qualification, I think, is a fellowship in endocrinology, but no one regulates it, whether I give it or anyone who has a ability to prescribe. And we do sometimes see patients who've just gotten hormones because someone went online and started it. And sometimes we have to backpedal and say, wait a minute, we need to make some adjustments to your treatment. Have a good afternoon.
Thank you, everyone. Bye.